All right, thank you. Those were 3 great talks. I hope you guys learned something from it. I always learn something from it, so thank you very much for that. But we've got some questions, and so I've mapped them out a little bit. But let me start here. So for Dr. Mohammed. Would like to hear more about primary tumors. Is the first tumor found considered to be the primary? Is there any other way to know or confirm what the primary tumor is?
That's a great question. So one of the factors that we would like to discuss once we diagnose the patient, what is your primary tumor is, because the systemic therapy response will depend on your primary tumor. So usually about most of the patient we can find the primary tumor with the anatomical scan, or either adding the functional imaging in the small bowel or the pancreas or the lungs, the most common 3 sites, with the gastroenteropancreatic about 55 to 70%. About 25% of the patient will not find the primary tumor, what we call an unknown primary, and sometimes we need more advanced help from our gastroenterologist, including doing the colonoscopy with ileal exploration or something like that, so we can find where is the primary tumor. Some patients will have a multifocal disease, either in the small bowel, or sometimes, believe it or not, we see some patients with 2 primaries, and it's not that common, but we can see it in some patients. So some of the patients we can see patients start with a small bowel neuroendocrine tumors, and then surprisingly, we found something in the pancreas later on, and we biopsy that because it's looking concerning, and we found he have another primary. But this is not the common case. So most of the cases we can get the primary tumor, which did spread to the liver or the lymph node or whatever other area or organs, through the anatomical imaging. Sometimes we need help definitely with the functional imaging or more advanced procedure to find where is the primary tumor. But remember, about 25% you cannot identify where is the primary tumor coming from.
Thank you. And of course, our pathologists really help us with primary tumor and their staining and different genetic staining, and can sometimes trace the origin of the primary tumor. This one for Dr. White. At what point would you use ablation for METs outside the liver?
Outside the liver, so if you have what we call oligometastatic disease, meaning you just have a couple of sites, depends on definition and depends on organ system what a couple means. But like the guy that had the shoulder thing, he had one side of disease, we would stick a probe and burn it. Or freeze it, or whatever modality you can use. Ablation really is dependent on size and location, so it depends on where it is. Is it sitting on top of the aorta? Not my favorite idea, to put a needle to burn something. I could do IRE there, but it really depends on, can I get a needle there, the location of it, and the size of it. In the liver, we're confined to about 3 centimeters, although we push it often. So size and location and number is when we would decide if we're going to be able to do an ablation for extrahepatic disease.
Thank you. Great. Number of questions for Dr. Evagawala, and they relate to the 70%, 90% threshold. So let me just hit the questions. Is there? Do you consider liver debulking if you cannot get 70%? Mayo Clinic says it should be 90%. What do you think of that? 2-stage liver debulking versus 1-stage liver debulking? I'll leave it at that for now.
All great. Can you hear me? All great questions. So the 70% versus 90% debulking threshold, like I said, very hotly debated topic. The one chart or graph that I had showed compared greater than 70% versus less than 70%. We saw a survival benefit there. There have also been numerous studies that have showed 70% versus 90%, and we still do see a survival benefit. The idea behind a 70% debulking threshold is that because there is a survival benefit, if we use that lower threshold, we'll be able to include more patients and help more patients. The NANETS guidelines currently support a 70% threshold in select cases, but a lot of that is dependent on where the tumors are. Are they close to important structures? Is there a way to achieve greater than 90% debulking, maybe in combination with our IR colleagues for some of those trickier tumors? So it's a tough question to answer, but there is still a lot of research being done about it. We know that we can achieve a survival benefit with greater than 70%, and so if that can include more patients and help more patients, many of us follow that guideline or that recommendation.
Thank you. So this is a question that I think we can, perhaps all of the panel members can weigh in on, because it was alluded to. How do you determine what sequence is best? Does one treatment preclude future use of other treatments? Dr. White, perhaps I could start with you on the preclusion.
Well, we talked about what precludes what in sequencing. So the answer is we don't know the answer to the sequencing of things. We know that depending on the grade of tumor, it's how aggressive we are going to be and whether we do concurrent therapy as opposed to sequencing of therapy. We often will do concurrent therapy for patients that have grade 3, or like that patient I showed you, the first guy, that had really was in a catabolic state, meaning that his tumors were just making him so debilitated that he was dying before his father-in-law's eyes, right, and our eyes. And so in those cases, you're going to be very aggressive and you're going to try to do concurrent therapy. So what therapy I chose in him, based on what he looked like to me, I needed to do something that was going to be fast and be effective and get him debulked quickly, in addition to he got CAPE-10. So CAPE-10 plus liver-directed therapy is what I did to him. Can I do TACE after Y90? Yes. Can I do Y90 after TACE? Yes. Can I do bland embolization after all of those? Yes. And I can tell you I've treated patients 13 times, especially metastatic neuroendocrine. We clean you up, you go on for a couple of years, come back, you've got recurrent disease, we clean you up again. That can be done all concurrently while you're on some sort of drug, systemic therapy. What prevents us from doing other therapies is when your liver starts to fail or you're not tolerating the toxicities of drugs. So we just have to be very careful about the toxicities related to our therapies, that it's not going to preclude other therapies. PRRT, yes, with liver-directed therapy for now that we know of. Can she go in and debulk you and I come in after and do a radioembolization? Yes. Can I do a radioembolization first and she take you to the operating room later? Yes, although she doesn't like to do that probably. But yes, she can. It's a little bit harder. It gets scarred in. She can tell you better than I. But so yes, all of those therapies can be done sequentially. I think it really depends on this multidisciplinary team. Make sure you're at a big center that can treat you appropriately and has all of those things in mind and has the long-term goal of how long you're going to live in mind. Because I could give you Y90 and you'll be dead in 5 years from liver toxicity if I'm not smart.
Thank you, Dr. White. So you've already invited Dr. Vagawala to answer something, but multidisciplinary tumor board team, this is how we figure out which therapy comes next. But can you talk about surgery after radiation treatments?
Sure. Well, in general, for localized disease in patients who are able to tolerate an operation, we recommend surgery up front. For that doesn't mean surgery has to be up front if the patient doesn't want that, or if the patient isn't a good candidate. I think we do staged operations. That was a previous question somebody had. And stage operations as well are something that we can always talk to the patient about. For example, if patients have both the primary site in the pancreas as well as liver disease, that would be two very large operations for the patient. Sometimes we'll take care of the liver disease first and then the pancreas. Patients who've undergone liver surgery who then do well, but several years later develop a new lesion, are also available to receive either surgery or liver-directed therapy, other treatments as well. So the main thing is preserving that healthy liver, and like Dr. White says, that often dictates how much surgery or treatment we are able to give the patient safely. In terms of timing, I would say there's a lot of factors that go into it, but in general, for well-differentiated, starting on somatostatin analogs. And if there's progression, then many of these other therapies come into play. If there's progression on somatostatin analogs, then surgery, really becomes a question, because if they've already progressed on that, offering a very large, potentially morbid surgery may not be the right answer.
The other thing I'll say is that if you have a peanut and you have liver disease, we oftentimes, as she alluded to, will address the liver disease first. So my surgeons will say, can you clean up the liver before I go and do my Whipple? Because now the risk of infection is higher. So we will do something to debulk the liver if they can't surgically debulk it ahead of them doing the pancreas surgery. So that sequencing can be pretty straightforward.
And Dr. Mohammed, you had actually mentioned some of the clinical trials that are really trying to tease out this, and I don't know if Dr. Ramirez has other information on other clinical trials. Do you just want to reiterate some of those points?
Yeah, thanks. It's a great question, and the sequencing of things is always tough. What are when I look at patients, what are the goals here? Am I trying to create stability of disease? Am I trying to generate a response? Do I need to shrink disease because of symptoms? So all of that really plays into all of our discussions. Now there's trials looking at this, and I'll talk about one in my talk, looking at Lutathera versus everolimus and which one should be given first. I think in the back of our minds, sometimes we have these preconceived ideas which one works better, but we don't know for sure. At Vanderbilt, we're actually opening a trial. It should be open next week, looking at sequencing for PRRT and whether or not patients should have surgery prior to PRRT to debulk the big tumors and how that's going to work. So everything, all of this, we discuss all of this with the multidisciplinary team, and we all have our ideas which should be, which should go first. And then at the end of the day, we discuss it all with the patients and come up with a joint decision.
Yes, as we said, neuroendocrine tumors are very different from other cancers. When you look at the colon cancer, for example, you have first, second, third line. I think neuroendocrine tumors are one of the cancers that does not have this specific alignment. And it depends on many factors. What is the grade, differentiation, how is the patient doing, what is your goals, and everything like that. We have a lot of treatment coming in the last 10, 15 years, and that's why we're starting asking the question, what is the best sequencing? And you can see in my presentations, there are two trials going to answer this question, which is the COMPOSE and the COMPETE trials. Going to answer the question for sequencing of PRRT versus other targeted therapy, according to different grades, including the higher grade, grade 3, which was not included in a lot of the targeted therapies before. In addition to that, some emerging data right now showing, for example, using the CAPTAM before the PRRT does increase the risk of MDS and leukemia. That's a discussion worth to have with your patient if they already got chemotherapy and they are qualified for PRRT. So there's a lot of factors and toxicity, and including your pathological information will really help determine some of the sequencing. We'll never have the right information until these trials have the final results and we know what is right and what's wrong. But some also of the trial did compare the targeted therapy with PRRT and did show, for example, PRRT is better to have it sooner than targeted therapy like sunitinib, and the study was positive for that. So we have some information, but the picture will complete once we have the final result of these trials.
Sure, and as every new medication comes in, there'll be a question of where does this fit into the whole regimen. So this is a quick question. I'm going to get the panel to take a rest, because this is a question for Carl, and Carl wants to know. He wants to get a show of hands for who has had PRRT treatment. 7 or 8. Not sure what the follow-up on that, Carl, was, but there it is, 7 or 8. There are a couple of questions related to sort of complementary therapies writ large. So what is your opinion of using black seed oil, vitamin C infusions in conjunction with conventional therapies? Anybody, Dr. Mohammed? This is a question that we get from our patients.
Yeah, I don't think we really can claim benefit of any of this complementary because it has never been controlled. It has never been studied in a good prospective trials. We have always our patients, the first thing that they do when they get diagnosed, they go to some website and they see all these, I call it false hopes of treatment for cancer. So until you have a prospective study that show, evidence-based results, I don't think we can really include any of this complementary because we really don't know much of the interaction between this complementary therapy and a lot of our targeted therapy or chemotherapy. For example, there is some medication, if you take it with capecitabine, we know it will decrease the efficacy of the chemotherapy. So I usually do not recommend them if we do not have an evidence base to support using these complementary medicines.
Right, and I'd point out that so there are vitamin C trials in other cancers, carcinomas, and they're based, as I understand them, on effects of vitamin C potentially on the mitochondria. Neuroendocrine tumors are not, at least grade 1 and grade 2 neuroendocrine tumors are quite different beasts from carcinomas. So when you look at complementary therapies that are out there in Google, you are probably looking at complementary therapies that have been used in more common cancers, which are the carcinomas, which are not the neuroendocrine tumors that most of you are dealing with. Going back to Dr. Vaghawala. So role of transplant, and I think transplant was mentioned in one of Dr. White's patients, but where does transplant come in?
That is also a tough question. So transplant is done rarely for well-differentiated neuroendocrine tumors. It has been studied in many different ways, many of it retrospective with small patient populations, or some of the data has been studied along with transplant in other tumor types. And so, it is part of the consideration in management for neuroendocrine tumors, but I'd say it's often one of the last resorts, given that we have these other treatment modalities.
All right, thank you.
I can
yes, please.
A little bit to that. There are some centers that will do multi-visceral transplants, and in their some of the these are all single institutions. There's a few in the U.S. that are doing this, and you need to be very selective on the patients and making sure that there's no extra abdominal disease. These patients are going on immune suppression afterwards, and sometimes we think that can cause that cancer to grow. So I think, they advocate, rather than it being the last resort, being the first resort. So this is actually, their chance to actually cure. If you have a pancreatic neuroendocrine tumor with disease in the liver, all right, new pancreas, new liver, and maybe that's all it's a long way to go. I've sent patients for it, and I've had some very good results, but they turn down way more than they accept. It's trading one thing for another, but I think it's certainly an option to consider.
Great, thank you. Another question for Dr. White. Side effects of Y90, side effects of bland embolization, are they the same? And how often do you see hepatic encephalopathy after embolization?
So you should see 0 hepatic encephalopathy if you're selecting the patients correctly. So what happens, hepatic encephalopathy means your liver stopped working because it's not filtering out the blood appropriately. So we very, very infrequently see it, but that's because our screening and our looking at patients ahead of time is so extensive. So what you can expect after the modality. So Y90, the most common side effect is fatigue. So I don't even call it a side effect. Everyone gets it, okay? You're going to feel tired for about 2 weeks, just like if you were to get external beam radiation. And then after 2 weeks, you're sort of back to normal. Of the therapies that I talked about, it's the easiest from which to recover. Bland embolization is the hardest. You wouldn't believe that, but it's the hardest. There's no drug. It's the hardest to recover from. The toxicities are the longest. So it's painful because it's blocking off the blood supply, and we're using very teeny tiny little beads. We're using 40 micron beads, so it hurts a lot. Those patients get what's called post-embolization syndrome, and all of them get post-embolization syndrome, which can be low-grade fevers. You sort of feel like you have the flu. You can have some abdominal pain, nausea, and vomiting. But bland is the hardest to tolerate. Chemoembolization fits a little somewhere in the middle. It's not quite as painful. Most patients we keep in the hospital overnight after we do any sort of embolization outside of radioembolization. Those go home same day. Other patients stay overnight to help us mitigate the side effects, and we'll give them a whole complement of drugs to help get through that post-embolization syndrome. That post-embolization syndrome from bland or chemoembolization, also about 2 weeks. The flu-like symptoms are about a week.
Thank you. A couple of questions here that are related, so I'll mash them in together. Cure. How long until you can say that you're cured? And can you do anything to reduce the recurrence if you are currently NED, no evidence of disease? Are there any dietary, exercise, lifestyles, supplements, again, things to avoid? So this goes to the question of how long do we follow patients who have no evidence of disease, say after a surgical procedure? Who would like to take that?
All right, I'll tackle this. It's a difficult question. Can a neuroendocrine patient be cured? And I think we do see late recurrences with this, and so even after you do what we think is a curative intent surgery, why do people recur 8, 9, 10 years later? So we don't know that answer. We can take our best guess. In other types of cancers, in lung cancer, for instance, we have a tumor, we take it out. Sometimes there's some chemotherapy afterwards, and people are NED. We think maybe they're cured. If they get to 5 years, we say you're cured. You don't need to come back and see us. With NET, it's a little different because we do know they have these, people can have late recurrences. So the guidelines tell us to follow people for at least 10 years. And I can tell you even after that, sometimes these are difficult conversations when with our patients saying, well, we're at 10 years, now what? Many times they say, well, I want to keep coming back and looking for this because I know we have these late recurrences, and I think that's fine. But I think, having patients pay attention to symptoms along the way, and even after, I tell patients come back next year, but if you're starting to develop problems, 6 months, into this, don't wait your additional 6 months to come see me. But yeah, these I think the to answer the question is, it's one of these things we don't know yet.
Right. It is a very difficult sort of issue to deal with, and my recollection when I got into seeing patients with neuroendocrine tumor a decade or more ago, that many of the guidelines had 5 years, and then it was 10 years, and we hear talks at the academic meetings about, well, maybe it should be 10 to 15 years, and of course the proportion of people that recur, the major proportion of people are going to recur in the first 5 years and 10 years, but there's a cost to a patient to actually come to clinic, get a scan, go through that burden of being tested and tested and tested, and perhaps they were cured by their excellent surgeon 10 years ago. It's a sort of a discussion. taking into account both the pathology and how aggressive the pathology was, whether there were any lymph nodes taken out initially, et cetera, what stage the disease was at. Let's see. There are a couple here that relate to carcinoid syndrome, and I'm going to take sort of speaker's prerogative here and maybe tackle them and ask anyone else. So, how does serotonin in excess and sandostatin lanreotide affect the heart? Serotonin is a hormone, is a chemical that is fibrogenic. It generates fibrous tissue. It can generate fibrous tissue in the heart and cause damage of heart valves. It can generate fibrous tissue in the abdomen and generate severe abdominal scarring conditions. And it's been known for a long time that it does this. In the 1990s, there were some medications that were given for obesity, fen-phen. Fen-phen was a combination of two different medications for obesity, but one of them which increased serotonin. And it was pulled from the market because of heart valve disorders, the exact same heart valve disorder, the tricuspid valve disease that is seen in carcinoid heart disease. So lanreotide, sandostatin, those are octreotide, those are medications which decrease the production of serotonin and therefore decrease the risk of ongoing development of heart disease. How many times can a patient have PRRT? Dr. Mohammed, Dr. White, a number of people could comment on this.
So most of the studies that we have for post-PRRT or retreatment with PRRT are retrospective or institutional experience. We have one study now which is going to be a prospective for retreatment. But most of the retreatment shows that the patient can get another PRRT treatment, provided that the first ones they have at least 1 year of disease stability. And the benefit that you are going to get from the second treatment will almost be half what is the benefit you got from the first treatment. The total amount of PRRT that you can get according to the retrospective data that we have are 3 PRRT treatments. The first one, maybe a year after that, you get another only 2 cycles, not the whole 4 cycles. And you can get another 2 cycles. So total of about 8 treatments or 8 cycles that you can get for the lifelong. And this is all retrospective data. And every retreatment will almost have the benefit of the first retreatment. We don't have any prospective data to show that. So this is all, again, retrospective and single institutional experience.
And of course, we don't have any idea at all about the repeatability of the alpha particle PRRT because we're just working that one out. Were there other comments, Dr. Ramirez? Did you want to?
I think. Again, this is sort of evolving. If you look at the Europeans, they'll say, "Yeah, we just keep going. We keep treating, and they'll get 12 cycles of treatment." Importantly, there's that 2% risk of MDS and acute leukemia. What the studies have shown is retreatment does not seem to increase that risk. So I think time will tell, and I think at some point, we're all hopeful that lutetium dotatate is going to go away, and we'll have a new option, and then we'll be asking these questions all over again.
Not that we're not grateful for lutetium dotatate or lutetium dotatalk, which one of our sponsors makes. Or is it anyhow. A question for Dr. Bhagawala. We talked a lot about pancreatic neuroendocrine tumors less than 1, greater than 2. Is debulking surgery possible with tumors of greater than 3 centimeters when it's in the head of the pancreas?
I would say yes, it is possible. The answer as to why or when we would do that, it just depends on the patient. Like we've talked about, the Whipple surgery has certain complications. It's a long surgery. If patients don't have good performance status or good health, they may not be good candidates for Whipple surgery, in which case enucleation may be something to consider. Depends on tumor location as well, where they may be a candidate for enucleation. So really a lot of considerations go into it, but I wouldn't say it's an absolute.
Sure, thank you. Question perhaps for Dr. White, but I think many of the panel could chime in. So functional imaging versus conventional imaging, which is better than the other? Is one better than the other? Why are both used? Which is best for long-term monitoring?
Yeah, that's a good question. It depends on if the tumor is functional or not, and if it's dotatate avid. So it's going to depend on your tumor type. Oftentimes, dotatate will be more sensitive in finding the small lesions, but regular imaging is good to give us sort of an overall view of where they are and what they look like. So for me and my patients, if we're looking at the liver, I'll get an MRI. If you're not getting MRs for your liver, you're not seeing the extent of disease. And they like to hide. So if you're getting a regular single-phase CT scan, which means you're going in and you're coming out once, that's not adequate imaging for the liver ever. You have to go in, come out a bunch of times. That's multi-phase imaging. And on MR, what you're going to want to look for is the different sequencing. So when we put contrast in, everyone thinks that's the best. It's not. So when we have these special sequences on MR, we're able to look at water. So the way MR works is it just shakes things. And so cancer cells have less water, so it shakes a little bit differently, and so tumors will turn white on diffusion-weighted imaging. So for me, I use diffusion-weighted imaging and T2. Both of those sequences look for fluid, and again, it's the way they shake the molecules on MR. So MR should be your first go-to for if you're just going to get regular imaging outside of the lungs you want CT. But again, whether you get a nuclear medicine scan and how we fold both of those in, nuclear medicine scans are time-consuming, and usually we don't get those as often. Usually we give those just to see the extent of disease, where it is, and then once we find it, we'll follow it up with other conventional imaging like CT or MR. But for liver, you want MR 100%.
And Dr. Mohammed, maybe you comment on, how are you following your patients 6 monthly, et cetera? What imaging are you using?
Yeah, I also want to add, so all the guidelines say that the beginning and the follow-up have to be with anatomical scan, either CT scan or MRI if you have liver lesions. And we usually get the PET scan, the functional one, either copper-64 or gallium-68, if you are well-differentiated, even including the grade 3 well-differentiated, which can be more than 50% of them having somatostatin expression. But this will be the imaging I'm going to get after the anatomical imaging. Once I start the treatment, the follow-up will be with anatomical imaging, where you can really measure the lesions and you can see if there is a good response or not. So beginning and follow-up with anatomical imaging, and usually the functional imaging will be after the anatomical imaging to see a prediction you are going to benefit from, for example, PRRT or not, or somatostatin analog. And maybe sometimes you find a new lesions in the anatomical scan, which does not look like cancer, or you are hesitant about it. You can also get a functional imaging at this time to see if this is active or not. Usually for the poly-differentiated high grade, we're getting the PET FDG, which is different from the other somatostatin receptor imaging. And sometimes we include that for the well-differentiated grade 3 as well. There is 2 papers recently mentioned. They always mention that the dual PET scan, which is a PET scan, copper-64, gallium-68, or the FDG, will be a prognostic. Once you have more FDG uptake, this patient does not do very well. But now we have a couple of papers mentioned they can also be predictive as well. So they found that if you have more positive PET scan FDG, and you are, for example, a grade 3 well-differentiated, this lesion which has the great uptake of the FDG, they do response less, have some optimal response compared to the lesion which does not have the FDG. So usually if my patient is a grade 3 well-differentiated or poly-differentiated, I try to push the insurance, all of them having an insurance denial for that, but I try to get the 2 scans, the PET FDG and the copper-64 as well.
Thank you. I'm just going to, you were mentioning grades there, and there is a question. Can a person have 2 grades of tumor, 2 different types of tumor in the liver, grade 1 and grade 2, or indeed grade 1 and grade 3? Yes is the answer to that. Tumors can have some grade inflation over time. Perhaps either of my medical oncology colleagues would comment more on grade inflation in tumors, starting off with low grade and moving up in grades.
Yeah, certainly that can happen. And you got to also remember, sometimes when we do a biopsy, it's just that. Where do you stick the needle? And you stick a needle in one side of a tumor, and you may have a Ki-67 of 2%, and then another tumor maybe 10%. So we do see this heterogeneity throughout there. We had published several years ago about that grade inflation, how the primary tumor may start out as a grade 1, but by the time we get to the lymph node and then to the liver met, those grades change. So yeah, we certainly see that, and we kind of, sometimes we can picture this on imaging as well. So you've got a small bowel tumor that you're imaging over time with liver disease, and the small bowel tumor isn't doing anything, but that disease in the liver is growing, and so then you do your biopsies, and now you find out, wait, this is, I thought this was a grade 1 tumor, this is actually a grade 3 tumor, for instance. So yeah, we certainly see it.
Great, thank you. A question that we get from our patients who come to us is, what's the general thought about the risk of developing NETs in children of patients? And does the type of NET play a role? For example, small bowel versus other NET. Dr. Mohammed, have you had that question from people?
Yeah, so usually most of our patients with pancreatic neuroendocrine tumor, I send them for genetics because there's a lot of hereditary syndromes associated with pancreatic neuroendocrine tumor. There's not much associated genetic abnormality with a small bowel neuroendocrine tumor. I don't know exactly the percentage of neuroendocrine tumor in pediatrics on top of my head, but I can say if you're a patient having pancreatic neuroendocrine tumor, according to the guidelines, especially if you are less than 50 years old, you should see genetics because a lot of genetic syndromes can be associated with that and can be inheritable. So you would like, if it is positive, some of your family members will be tested for that as well. But I'm not sure if one of my colleagues have a specific percentage of neuroendocrine tumor in pediatrics.
Sure.
I really don't know about that.
They are rare, but they do happen, and perhaps it relates to their risk ongoing through their lifetime. Perhaps a question for Dr. Vagawala, and it's perhaps just a clarification of the terminology. In medicine, we have 3 different terms that mean the same thing, and we have three terms that sound alike that mean entirely different things. So is there a difference in nets of the small intestine and nets of the small bowel?
I would say that's just a difference in terminology. So small bowel or small intestine, we're referring to the same thing as opposed to the colon or rectum, which we would refer to as the large bowel. The duodenum has its own name. That's that portion of the small intestine or small bowel that sits right next to the pancreas. That's that first portion right after the stomach. So yes, they have different names, but I would use small bowel and small intestine interchangeably.
Right, and you had talked about tumors in the jejunum and ileum, yes. All small bowel.
More names for small intestine.
Yeah, right. Can carcinoid syndrome, carcinoid crisis happen only during surgery or procedures, or can it be an ongoing issue with a patient? I'm going to chime in on this a little bit. Carcinoid crisis, we certainly have heard about it this morning in terms of surgery. Can also be an issue both with PRT occasionally and liver-directed therapies. But carcinoid crisis can occur in a person generally with a fairly strong carcinoid syndrome to begin with a lot of tumor burden, particularly in the liver, and then some precipitating event. So doing okay, having lots of flushing, but dealing with it, but then gets pneumonia, and gets septic or has a heart attack and a lot of other stressors coming in, we sometimes talk about the 5 E's that can stimulate carcinoid symptoms, one of them being epinephrine. And I then think about these stressful events like heart attack. There's a lot of adrenaline going around. Perhaps that's the mechanism whereby some people then trigger into a much more severe carcinoid episode, which may get to the level of crisis. Does anybody else want to chime in on that, or is that enough? Okay, Mr. Wayman, take it away.